Thank you, Warren. The last speaker that we've got for the afternoon is Dr. Joseph Hockley. Joe is an endovascular surgeon, or a vascular surgeon from Sir Charles Garden Hospital. He's a unique vascular surgeon in the sense that he's got an extremely wide, very wide of practice. He will be one day working with kids doing complex aortic work. The next day he'll be doing varicose veins and pulling out first ribs for thoracic outlet syndrome. And then on days like today he'll be doing these massive retroperitoneal open resections of sarcoma. And so he's got a huge amount of experience across a lot of different clinical situations. He's also a senior clinical lecturer at Curtin University, and he's a part of the Heart and Vascular Research Institute at the Harry Perkins Institute at Charlie's. And so we'd just like to welcome Joe up to the stage to talk to us about major limb and abdominal bleeding and the use of REBOA. Thank you, Joe.
Thanks, James. Hi, everybody. Thanks, Tanya, for the invitation, for you and the organising committee. I'm talking about major limb and abdominal bleeding and the use of REBOA. It's not nearly as cerebral as the last lot, so I make apologies for that, but I'm only a surgeon. So I think if we're talking about injury as a leading cause of death in Australia, we know that hemorrhage is responsible for about 35% of pre-hospital deaths and about 40% of deaths within the first 24 hours. And those of us that deal with them know that non-compressible torso bleeding is extremely difficult to manage. And so I guess to start off with, what is REBOA? REBOA stands for resuscitative endovascular balloon occlusion of the aorta. The easiest way to think about it, well, it was initially described in the 50s, but at that stage they had a really high complication rate and so abandoned it, but then as technology's improved, the technique's been revisited. And the easiest way to think of it is it's an endovascular aortic clamp. When do we use it? Well, it's used in trauma, in my practice primarily in ruptured aneurysms, and then sometimes in postpartum hemorrhage. But the concept of using a balloon to occlude vessels all around the body we use most days in modern endovascular surgery. The evidence is pretty slim, and so if we look at a few of the physiological parameters, one of the easiest to measure is that you get an improvement in systolic blood pressure, but that would be expected if you blow a balloon up in the aorta. If we compare it to thoracotomy, it's probably got some benefits related to pH and lactate. Certainly seems to need a little bit less fluid support and less noradrenaline. But if we're looking at mortality, there doesn't seem to be any clear relationship or any benefit. So those that have studied it, there's been a wide range of results. There's been some consistent positive effect, no clear reduction, deaths don't happen in ED, that's probably a good thing. Higher mortality in REBOA, although I'll mention that in a second. But the only meta-analysis that's been done has shown that there's probably a slight benefit of REBOA when compared with thoracotomy. But there's obviously pretty significant issues with the research. They're really small samples, they're a really heterogeneous group. And the group that Norrie published on, they admitted that REBOA was their last ditch. So the patients were kind of 1 foot out the door when they tried it, and that probably explained their high mortality rate. But in ruptured AAAs, at least in most contemporary vascular centres, this would be our standard of care, whether we're going to fix them endovascularly or open, is that you stick a balloon up in the aorta while they're still awake, and then if they're going to be fixed endovascularly, we try and fix them endovascularly under local anaesthetic. If they're going to get an open repair, you then put them to sleep. So the complications, there's actually a really nice review article done by Petroni's group, 1,300 patients, so it's a really good number. I highlight the acute kidney injury because I feel like there's a zero missing on both of those numbers. Certainly from my ruptured aneurysms, I would see acute kidney injury in every single patient. And anyway, that's the bit that I highlighted. The rest of it's all actually really impressive. Their femoral artery thrombosis was low, their limb ischemia rates were low, vascular injury were low, distal emboli were low. That's all pretty good, especially considering the patient group that they're dealing with. The indications for REBOA, this is where it all gets a little bit wafty, because the suggested trigger points, as you can see now, most of us would see these sorts of trigger points in a lot of patients every single day. And then, so it goes from sort of, you know, patients that look a little bit sick but you're not quite sure, to patients that are pretty much dead. And so clearly there's probably somewhere in between, which is actually the sweet spot. There's some contraindications which are also interesting. The first one, as far as I was, I always thought that if you had PEA for more than 10 minutes, you were dead. Thoracic injury and hemorrhage, I've actually used the REBOA for ruptured thoracic aneurysms and it actually works extremely well. So I think if you've got experience, you're in a good centre, and most importantly, you've got good imaging, then that's not necessarily a contraindication. I've also used it for a ruptured aortic dissection, which was thoracic aortic dissection. So again, that's a relative contraindication, but you definitely need good imaging. And then clearly cardiac tamponade, you've probably got the wrong pathology and severe comorbidity, so the patient's not going to survive. So if you're thinking about starting up a REBOA program, and any of you that work in a unit that has a fairly busy vascular unit, there will be people that are doing REBOA anyway within your hospital. But most of the places where it seems to be of most use is in large trauma centres, and I think part of that's because there's, at least in WA, there seems to be a fair bit of funding associated with the trauma centre, and so that you can get the extra equipment that's required. You need trained people, and the basic infrastructure that's required is, I think you need an ultrasound for your punctures, you need a C-arm or some sort of mobile II, or even better, a fixed II that will help you guide your wires and your balloon placement, etc. And then, in an ideal world, you have a hybrid theatre or some sort of hybrid setup within the emergency department itself, where the patient can be on the same table, have the image intensifier, but then get their CT scan once you've got the balloon up. You need a readily available kit, and I'll go into that in a second, and then you need a cut-down tray for if access proves to be too difficult. But then, most importantly, you need an established downstream clinical care. There needs to be some guidelines and governance around it, and there needs to be ongoing training, because even in really busy centres, this sort of stuff doesn't happen very often. So moving on to some of the practical aspects, I think most people would agree that the person who decides whether the patient gets their REBOA is the person who's going to fix it. But who puts it there is actually whoever's really trained. And with the greatest respect to some of the trauma surgeons that I've worked with, they're not that great with wire skills. And there'll be plenty of people around the hospital that are better, and certainly plenty of people around the hospital that are available. And so that might be your interventional radiologist, ED consultant, ICU specialist, anaesthetist, etc. But there does need to be a hospital guideline and some sort of accreditation process, because you don't want people just winging it. Where it gets done, again, that kind of depends on what your local capabilities are, but certainly you can do it in the ED. You just need a mobile C-arm and an ultrasound, really. But in an ideal world, it would be some sort of hybrid setup, or an OT or interventional radiology department. Early versus late, I've never quite understood this argument, because an early sheath placement, in my mind, is always better. There's no point waiting until the patient doesn't have a pulse, and then that makes it much harder to get into the artery. And at the very least, you can place a small sheath, which can be upsized, and I'll go into the practical aspects soon. But that small sheath can be used as an outline. This staged approach is probably pretty reasonable. So if the patient's in severe shock, just do it. If they're a transient responder, then I wouldn't say insert the REBOA. What I would say is insert the big sheath and the wire, and then you can have the balloon even sitting on the wire if you want to. But if you stick the balloon in the aorta, it'll just accumulate clot. And so you're better off to leave it out of the body until you need it, but it'll take 5 seconds to put it back up, put it up over the wire and then inflate it. And then if they're not in shock, just place a sheath and then have the gear nearby, and then you can do something pretty quickly if required. It's usually femoral access, although if you've got a bit of experience with it, then using upper limb access is also relatively straightforward. And now that there's a newer balloon that's available in Australia, which is only 10 French, and so that does make upper limb access quite reasonable. We do use it sometimes for ruptured aneurysms, because it allows us, particularly if we're going to fix it endovascularly, because it allows us to insert the stent graft from the groins and the balloon doesn't get in the way. So where and how long? Generally, for the sake of REBOA, we divide the aorta into 3 segments. There's the thoracic aorta, then there's the visceral aorta, or zone 2, and then there's the infrarenal aorta, zone 3. If you're placing a balloon in zone 1, it's generally for the intra-abdominal or retroperitoneal type bleeding. It's worth aiming for a 15-minute maximum time for the balloon, but trials that have been done in humans and animals suggest that probably 30 minutes is about the maximum time. That's not to say that you can't leave it up for longer, but that's when you need to have a really serious think about whether or not you're going to give some heparin. Zone 2, generally try and avoid it, and I'll show you an ugly picture that I had to live through. And then zone 3, it's pretty useful for pelvic or proximal lower limb bleeding where you can't get a tourniquet. And the times that you can leave the balloon inflated there are much longer. But again, if you're getting out to 60 minutes, then really seriously consider some heparinization. But generally speaking, less is more. So there's a bit of discussion around about full versus partial versus intermittent, and the truth is nobody knows what's best. You can generally, my general approach is do it depending on what the patient looks like. What I would suggest though is once you've inflated the balloon, a partial or intermittent deflation is a useful technique, because once you deflate the balloon, they get a big reperfusion, and then that can sometimes undo a lot of your good work. It's worth always remembering the cost. So in 2021, the kits were about $6,000. They're probably almost double that now. No, I'm being, but in WA anyway. They expire in 3 years, and the training costs are not insignificant. So moving on to the technique, as I said, I think ultrasound's a must. It's really hard to successfully puncture a femoral artery when there's no pulse or if there's minimal blood pressure. And so it's definitely worth practicing doing it with an ultrasound, and then it doesn't slow you down at all. In fact, if anything, it speeds you up. You need an image intensifier or mobile C-arm. And then the sorts of kits that you need to start to think about, and I've got a more detailed picture of it, is a soft wire to get in position, a catheter, a stiff wire, and then a sheath, and then a balloon. And the idea is, or my suggestion to you is, when you inflate the balloon, position it right at the end of the sheath, and so there's longer sheaths available. And the reason for that is the balloon will want to migrate, particularly once they get a blood pressure back, and the sheath will help hold it in position. That's I know it doesn't project that well, but that's the sheath there, and then the balloon is sitting on top there. Closure is, this is sort of, I guess, dependent on who's doing it, but you can do a pre-close technique with this device called a ProGlide. There's a newer version of it now. But essentially what it is a percutaneous stitch that you can put into the front wall of the aorta, front wall of the common femoral or whichever vessel you're using. You don't then, it's got attached to a slip knot, which you can then slide down, but you don't need to do that immediately. You can put a tegaderm or something over those over those wires and leave it for quite a few days if you need to, and then close it later once you've pulled out the big sheath. Or the old-fashioned post-close, which is how we've generally done a lot of it in the past, which is to cut down and repair the artery manually. Although if you're only using the 10 French sheath, which is now available, you can do a ProGlide as a post-close whenever you like for that. And although I have to say I haven't used these devices, the Manta, some of you may have, they've only become available in Western Australia recently, but you can close vessel holes up to 18 French, which is pretty impressive if it works. So this is, I guess, a little bit of a detail of what is worth having in your pack, and you need to divide the wires into your access wire and then the wire that you're going to put the balloon over. So the first wire is the access wire, and that should be a soft wire because that'll be the one where you get yourself into position, and if it goes into a renal artery or into the SMA and it's a stiff wire, it'll do some damage. Then you need to put a catheter over the soft wire, and I'd recommend one of the beacon tip ones just because they're easy to see, and particularly if you're in a sort of trauma environment where there's a lot of stuff, you want to be able to see it as easily as possible, and we tend to use the Vansky 1 or 2. And then the stiff wire is the wire that you deliver the sheath and the balloon over, and that will be usually an Amplatz or a Lundequist, or at a stretch it'll be a Supracore. Generally, when selecting your sheath, the longer sheaths are the better ones. Most of the big sheaths are about, sort of, as you can see down the bottom there, 33, 28 centimetres, and that's just not quite long enough. That'll sort of get you to about the renal arteries, which is where you don't want to position your balloon. So we tend to use the Gore Dry Seal. It's got a 10 French minimum size. It goes up to 65 centimetres. But the other readily available sheaths, which are very good sheaths, are the Medtronic, but it's only 28 centimetres, and then there's the Cook Flexor, which is up to 90 centimetres. The only thing with the Cook is they've got a huge range, but it's a little bit more flimsy, and so it doesn't sort of have that rigidity to hold the balloon in position, and so that's why we've erred towards the Dry Seal. And then the balloons in Australia, there's 3 that are available, the aortic occlusion balloons. They're all good balloons. I don't have a strong preference for any of them, but there's the Cook one, the Medtronic one, and then the Gore one. The advantage of the Gore one is it's 10 French. And that's only become available in Australia, I think, in about the last 18 months. Pitfalls. Now, this is the one. The access complications are always the problem, but hopefully that's why you've got your friendly vascular surgeon to help fix that at the end. To be fair, if you've got a patient in extremis, this is not really something that needs to be worried about too much. This is probably the number one problem, is that you have a patient who's got a blood pressure of 50 and looking like they're going to die, then you blow up the balloon and their blood pressure goes to 160 and everybody will stop. Theatre will say, oh no, that patient's too stable, we'll do this appendix. Everybody in the ED will slow down, you can't get your CT scan, etc., etc. And it's a bit of a pity to have to deflate the balloon to get people to speed up. Reperfusion, be aware of this, because when you drop the balloon, particularly if it's a thoracic balloon, you're then reperfusing the whole of the rest of the body and they'll dump their pressure really badly, and that can cause a problem in and of itself. And then the final thing is, if you've got your balloon inflated for too long, you'll get clot forming around it. And I don't know how well it's projecting, but you can see a big flow void in the middle of that aorta, and that's all clot. That artery that's not filling very well is the renal artery, and that's all full of clot. And you can't see it out of picture, but this patient's SMA was all full of clot and they died. So be aware that if you've got your balloon up for a long period of time, that will form clot around it. So I draw your attention to this report that was written for New South Wales Health I think it was in 2021. It's an excellent report, and if you've got ideas about how you want to set it up in your hospital and those sorts of things, and you need to sort of get hospital executive on board, then I would recommend using that one to help you, because it's a really nice summary of all of the recent evidence that's available. That's all I've got. Thanks.
Just up on the chairs. So thank you, Joe. That was very insightful. It doesn't always